Hello all. Am I audible? Can Harshita tell me if I'm audible or not?
Yes, Thanusha, you're audible.
Yeah.
Yeah,
Okay.
you are.
Okay. Okay. So hi everyone. A very good evening to all, and thank you all for joining the case discussion today on Hydroxyl. So we have Dr. Mohammed Shahid today with us as the supervisor. Sir is a senior resident in the Department of General Surgery from RRMCH Bangalore. And today's case presenters are Samiksha, a fourth year medical student from Seth GS Medical College Mumbai, and Thanusha, a fourth year medical student from AJIMS Mangalore. And the discussion is moderated by me, Tanisha Singh, and I'm a third year MBBS student from Srihar, Chennai. So we will get right into the case discussion. And before we begin, I just want to say that we'll be having the case discussion first, and after that we have MCQs. And for the MCQs part, all of you will be getting 15 to 20 seconds to answer the particular MCQ, and you can type down the answers in the answer chat in the chat box. All right. So we'll get right into it, and over to you, Tanusha.
Am I audible?
Yes, Tanusha, you are.
Good evening, sir. Harshit, on the next slide, please. Presenting before you a case of a 37-year-old male, Mr. XYZ, hailing from Attawar, Mangalore, who studied up to 10th standard and is a construction worker by occupation. He was admitted on 13th November 2021 and examined on 14th November 2021. Chief complaints. The patient presented with a swelling in the left side of the scrotum for the past 10 months, history of presenting illness. Next slide, please. The patient was apparently normal 10 months ago. Then he noticed a swelling on the left side of the scrotum. It was insidious in onset and has gradually progressed to the present size of 8 into 6 centimeters. The swelling doesn't reduce in size on lying down or increases on coughing. Next slide, please. There's no history of pain. There's no history of trauma. No history of fever with chills and rigors. No history of sudden increase in size of the swelling or any other swelling. There's no history of loss of weight. Past medical history. There's no history of similar swellings in the past. The patient is not a known case of diabetes mellitus, hypertension, asthma, TB, epilepsy, or any other chronic illness. There's no history of any previous surgeries or hospital admissions. There's no known history of drug or food allergies. Next slide, please. Drug history. There is no significant history. There is no history of steroid intake. Next slide, please. History. There's no significant family history. Next slide, please. Personal history. Patient consumes mixed diet. He has a good appetite. His sleep is adequate. His bowel and bladder habits are regular. Patient consumes alcohol occasionally. There is no there's no other substance abuse. Summary. A 37-year-old gentleman presented with a left-sided painless scrotal swelling, which was insidious in onset and gradually progressive for the past 10 months, and it is not associated with any trauma or fever. Differential diagnosis can be hydrocele, inguinal hernia, hematocele, filariasis, and varicocele.
Thanusha, right? A very good evening, everyone. A rather modest presentation, but okay. There are a few questions we need to address right now. All right. Can we go back to the slide of history of presenting illness, please? Right. Thanusha, you asked a history whether the swelling reduces on lying down.
Yes, sir.
Why did you ask this, Thanusha?
Inguinal hernia and varicocele, lymph varix, they reduce on lying down. If it's congenital hydrocele, it slowly reduces on lying down, sir.
Can we go to the next slide as well, please? Right. You asked for history of pain. Why exactly did you ask for history of pain?
If it's in case of acute epididymolysis, there's pain, like there's fever and swelling which is associated with pain, sir.
Will we have a significant swelling which is gradually progressing from the past 10 months with this much amount of collection here?
Yes, sir.
Okay, so you mean to say that you want to rule out epididymoarthritis, which the swelling is going to have for the duration of 10 months, and it has slowly progressed from 8 to 6 centimeters in size, approximately. So, what else could there be?
Pain, like trauma also, sir.
Agreed.
Swelling,
Trauma is a separate question altogether. Why are you looking at pain right now?
like if it's an acute inflammatory condition, it'll be associated with pain, redness, and swellings.
Okay. Why do you want to rule out fever with chills and dry eyes?
In case of filariasis, the swelling may be associated with fever, chills, rigor, and pain also.
Okay, there's also you have asked for a sudden increase in size of the swelling or any other swellings in the body. What do you mean by that? Why would a swelling increase suddenly in size?
If there's a malignant change, then there can be a sudden increase in size, or an
Malignant
incident.
change of what, Thanusha?
So, like the swelling or the malignant growth usually is rapid growing. So
Okay, is the seminoma rapidly growing?
it is malignant.
It is definitely malignant, but is it rapidly growing? Okay. All right. You also have a history of loss of weight. I'm concurring that that's probably because of malignancy, correct?
Yes, sir.
Okay. Can we go to the history of yes. Can we go to the history of differential diagnosis, please? Right. A hydrocele is an acceptable diagnosis. You have the first differential diagnosis in hydrocele. I accept this based on your history. Why an inguinal hernia, doc?
There is no decrease in size of swelling or the
There is no history of increase of swelling while coughing.
inguinal swelling, like originally.
Could be an inguinal swelling, but you very clearly told the swelling is in the left side of the scrotum and does not reduce. Mm-hmm.
He had no like he's not a known case of any pulmonary cause for any
Shouldn't be required to.
shouldn't be.
Any other person can also have an inguinal hernia. But why a differential diagnosis here? Just because of scrotal swelling, you want to rule out an inguinal scrotal swelling, is it? Yes, no? Yes, okay. All right. Hematocele is fine. What is filariasis doing here, doc? Filariasis is what, basically?
So it
It's
can
an
be like
infect.
filariasis. One of the cause can be same as hydrocele, like accumulation of fluid
Okay.
in the
It may
place of
precipitate as a
accumulation.
secondary hydrocele, definitely. Okay. So this is in regards to the filariasis causing a secondary hydrocele, is it? Okay. All right. Okay. So what about scrotal filariasis? See, we understand that filariasis is there. One of the differential diagnoses for a unilateral limb edema is filariasis in the coastal belt of southern India. But why exactly How does scrotal filariasis present? Any idea?
It'd be painful, sir. It'd be associated with fever and
May or may not be. Most of the filariasis, when it presents symptomatically to a surgical department, will be because of a dead parasite. Okay? Vagina bancrofti will be dead, and that will start blocking the lymphatic vessels. However, okay, if that, well, okay, fine, I'll consider varicocele as well. All right, let's consider the examination, please.
Samiksha will continue.
I'll continue with the examination part. Next slide, please. Harshita. So, my patient is a young male patient who is conscious, cooperative, and well oriented to time, place, and person. His general appearance is moderately built and actively nourished. Height is 150 centimeters, weight is 52 kgs, and the BMI is 22 kg per minute. On examination, pallor was absent, icterus absent, cyanosis absent, clubbing absent, generalized lymphadenopathy absent, and no edema. His vitals were the pulse rate was 78 beats per minute, the respiratory rate was 14 cycles per minute, the blood pressure was 110 over 80 millimeters of mercury, and he was perfect right. uh, Local examination. After examining explaining the procedure to the patient and getting consent, the patient was adequately exposed from nipples to the knees, and the local examination was done with patient in standing position in the presence of a male attendant. On inspection, left-sided scrotal swelling, globular in shape, extending from the root of penis to the base of scrotum. Skin over the scrotum appears stretched with loss of reverse squeeze, and no redness over the swelling was seen. No scars and sinuses seen. The penis was in midline. No increase in size and offering. Size does not reduce or lying down. Abdominal and inguinal region appears normal. The right side is normal. On palpation, the inspectory findings were confirmed. There was no local rise of temperature, no tenderness. The swelling measures about 8 into 6 centimeters and was able to get about the swelling at the root of scrotum and feel the cord structures. The swelling was cystic in consistency. The fluctuation test is positive, trans-elimination test positive, net testes is not palpable separately from the swelling, the cuff impulse is absent, swelling is not reducible or lying down, normal left cord structures felt, and right side of the scrotum was normal. On systemic examination, CVS, S1 and S2 are heard, no murmurs heard, RS normal vesicular breath sounds heard, CNS no focal deficits noted, abdomen soft, non-tender, no palpable organomegaly, lymph node examination showed no palpable inguinal lymph nodes. Summary. My patient, a 37-year-old male, came with the chief complaints of swelling in the left side of the scrotum for the past 10 months, which does not reduce on lying down and is not associated with pain, fever, or trauma. On examination, the swelling was cystic in consistency with fluctuation and trans-elimination test positive with no cough impulse and was able to get about the swelling at the root of scrotum. Uh, my provisional diagnosis is a 37-year-old gentleman presented with a left-sided globular swelling which was insidious in onset, gradually progressive for the past 10 months, and is currently measuring 8 by 6 centimeters. It is a painless, non-reducible scrotal swelling which is not associated with trauma and fever. On examination, was able to get over the swelling and feel normal cord structures. The swelling was cystic in consistency, fluctuant, trans-eliminant, and testis was not palpable separately. This is probably a case of left-sided primary vaginal hydrocele. Next slide.
We'll take a
Investigation.
pause here now, Samiksha.
Yes,
All righty. Okay. Thanusha as well, right? The other presenter. Let's have you online as well now. Okay. In a differential diagnosis, you could also have included the tumors of the testis. Why was it included?
there was no rapid loss of weight and unexplained loss of weight or any sudden shift in the size of the swelling.
Agreed.
And
Why not a differential diagnosis of an epididymal cyst or a spermatocele? Both the swellings occur in the scrotum.
yes, sir.
Both the swellings do occur around the testis, plus or minus.
Yes,
You would not have come
yes,
to a
sir.
differential diagnosis only based on the history there, correct?
Yes,
So,
sir.
probable diagnosis of a hydrocele, epididymal cyst, then the rest of the diagnosis of inguinal hernias and hematocele and pyocele and chylocele could have been included as well. All right. Samiksha, why a primary vaginal hydrocele? Why not secondary hydrocele?
So we have tried ruling out other secondary causes of a hydrocele
Which are okay.
like TB, filariasis.
Tuberculosis is not the first differential diagnosis of a secondary hydrocele. However, continue.
Then we've tried ruling out filariasis
Okay.
um, and any other inguinal scrotal swelling like inguinal hernia. We've tried
Okay. How
them.
did you rule out inguinal hernia?
So there is no cough impulse and the swelling
Okay.
is not reducible or lying down.
Okay. So this is your answer. This is the justification for why it is not an inguinal hernia, is it?
Yes, sir. And over the
Exactly.
examination,
Correct. Yeah. So just on examination, let's do the examination right now. Right.
yes,
I have a strong feeling that this is a case of a secondary hydrocele. You have to prove me wrong. So how will you prove me wrong?
was,
Testis.
as
Testis
well
is.
as on the other hand, when it comes to secondary hydrocele,
Uh huh.
sorry.
Yeah. Basically, what I'm trying to ask you is, what is the difference between a primary vaginal hydrocele and a secondary hydrocele?
So the amount of fluid in a primary vaginal hydrocele is more as compared to a secondary hydrocele, and
Agreed.
the testis can be felt in a secondary hydrocele as well, while it cannot be felt separately in a primary hydrocele.
Okay, you're right. So I quote, this is directly from Bailey Law, it says that hydrocele in secondary hydrocele is lax and typically small. The underlying testis is usually palpable. And this is a direct quote from Bailey. All right. Yes. All right. Now, why not an epididymal cyst? What is making you stop from diagnosing this as an epididymal cyst? You did mention a last line, correct, in your examination. What was the last line in the examination? Can we just go back to the examination, please?
Normal left cord structure.
No, that's not exactly what I wanted to ask. Yeah, correct. There was a normal left cord structure.
Left cord
Also,
structure.
was the testis palpable?
No, sir, it was not
In an,
completely palpable.
what do you understand by an epididymal cyst, doc?
The testis
An, ep-
will be palpable.
an epididymal cyst is a cyst arising from the epididymis. Simple, correct. If you just draw a diagram of the testis and epididymis is a completely different structure from the testis, correct? So, irrespective of what and how big the epididymal cyst is, you will still be able to palpate the testis. However, that may not be the case. We have operated in a case, the ultrasound report also told it's a hydrocele. When we went in, the testis was pushed off to one periphery, and we identified that was probably an epididymal cyst, approximately around 12 cross 10 centimeters. Right? Unfortunately, we couldn't do a preoperative diagnosis for this. So sometimes an epididymal cyst will be completely ignored. How will an epididymal cyst present if you're on clinical examination, when you're examining the scrotum? Let's consider you have an epididymal cyst. How will it differentiate from a hydrocele?
So there will be localized bulge around the
Localized
testis.
bulge around the testis. Okay, one probable is, okay, let's consider you do have it, but it's a very huge swelling. Let's consider it's around 8 cross 6 centimeters swelling, right? How else will you identify this? You did the fluctuation, right, for this test.
Yes, sir.
All right, how did you do that? How did you elicit the fluctuation?
It would be a cross fluctuation since hydroxyl is a large swelling within the
Okay,
epithelium.
it is fluctuant. How do you exactly elicit fluctuation? You will fix the swelling with two fingers of an opposite hand, and opposite two fingers of the other hand will try to push the fluid inside. You will see a
Fluid.
movement in the hand fixing the swelling. Am I correct?
Yes,
Correct.
sir.
Now, if it is an epididymal cyst, how will the mobility be of an epididymal cyst? Let's consider you're able to feel the testis separately and the epididymal cyst separately. How do you differentiate from a spermatocele and an epididymal cyst now? All right. An epididymal cyst and a hydrocele are transilluminant. A spermatocele is not transilluminant. All right. This is one of the primary differential diagnoses. Second, an epididymis arises from the epididymis. So if you're able to get the testis, tuck the testis down, pull it down, and keep it fixed, the mobility of the cyst will get restricted in the coronal section. The upwards and downwards mobility there gets restricted. However, the horizontal mobility will be present. Now, epididymal cyst is usually multiple collections of cysts in the epididymis. And that's why there's a very famous transilluminant finding called Chinese lantern appearance. I don't know how many of you have seen Chinese lanterns. A very beautiful festival, you know, it happens in China. They have these lanterns being pulled off. It's a similar kind of appearance. All right. Doc, also, these are the stock questions which all of you need to know. Triathylation test is positive in what all swellings? Can you just list them?
And yes, sir, Menezes,
Okay.
cystic hygroma,
Okay.
granula,
Okay.
Epididymal cyst.
Epididymal cyst, yes. A hydrocele, yes. Okay. Fluctuation test is positive in which all conditions? Generally speaking.
in swellings which contains fluid based.
Fluids, probably cystic swelling. Correct. Agreed. Cross fluctuation is seen where?
Large swellings in fluid.
No. Have you heard of a compound palmar ganglion? A compound palmar ganglion. A ganglion is basically a synovial sheath filled with synovial fluids. So it should technically be able to elicit a fluctuation test. Correct. Now, because of the flexor retinaculum on the wrist here, if you have a compound palmar ganglion with extending in front and behind, you will be able to see a cross fluctuation or cross fluctuation that situation. All right. How would you like to investigate this case, doctor?
Uh, so firstly, I would like to do the routine examination or the CBC, the WBC count. Uh,
Let's go to specific
then
examination.
and the specific examination investigation that I would like to do is the USG scan.
Okay, a USG scan report comes to you telling that you have a hydrocele of approximately 8 cross 7 centimeters with testis. The vascularity of it is normal. There is no other problem around the structures. There is no hernias. The rest of the opposite side is normal. How would you like to proceed?
The only management for hydrocele is a surgery, so I would like to
Can we move
proceed with
front? Can we move the slides as well, Harshita? All right. Yes. So, how would you like to proceed, Samiksha?
Sir, I would like to do in three. There are three kind of surgeries that can be done. Next, step we have
Okay, let me rephrase this question. What all types of treatments do you know for a patient of a hypercelic?
so there can be cancer.
All right, let's deal with your slide as of now. The treatment part of it has three parts, correct? We have Lord's plication, Jabolis procedure, and excision of the sac, correct? Now let's
Yes.
consider. I'll give you a scenario. A 92-year-old male patient, previous two ischemic heart diseases, PTCA twice, CABG once, abdominal aortic aneurysm of 4.5 centimeters with seizure disorders, with probably chronic renal failure, comes to you with a massive hydrocele of, let's say, 20 into 18 centimeters. How will you deal with him?
I wouldn't like to operate on this patient. I will stop it.
Mhm.
Maybe we can insert a drain and drain the fluid.
Insert a drain and drain the fluid. What
Maybe
will you insert?
a drain by giving an incision. We can insert a drain.
Okay. See, in a situation that a patient is unfit for surgery, I would, if at all it is causing him any problem. At 92 years of age, this doesn't seem to be a concern of any primary problem per se, unless it is pushing his testes too much or he has a micropenis and it's having a problem in him passing urination on a certain sort. What we can do is we can try to aspirate the fluid. However, after aspiration of the fluid, it will recur within a week. So this will be only restricted to those situations where in which the patient is absolutely unfit for surgery. All right. Let's consider a patient came to you with history of trauma to the testis, an 18-year-old boy. You get a scan done. It shows a small hydrocele of around 20 cc around the right testis. Vascularity is normal, lie is normal. There is no compromise in the vascularity or anything of that sort. What would you like to do?
If it's a trauma, it might be a hematocele due to
Correct. No,
damage
but
to the
the
vessel.
ultrasound very clearly tells the clear anechoic area around the testis with no internal echoes or no debris. So hematocele is very ruled out, and the sonologist is very confident that it is absolutely an hydrocele. How would you proceed with that?
So under local anesthesia, I'll drain the fluid.
Why? An
Since it's a
18-year-old
small
boy with
amount,
history of trauma, why do you want to drain it? Usually, what Bailey tells is that small hydroceles can be left like that unless it is bothersome to the patient. Okay, as I said, 10 cc fluid, the patient may be absolutely fine unless it is progressing bigger or reducing. Okay. Other than surgery and other than the methods I've told, do you know of any other method of treating a hydrocele patient?
so there's this angio surgery which is used for a small size
I'm not talking
hydrocele.
about surgery. I'm not talking about surgery. Is there any
Then
other method by which you can treat the patient other than surgery and other than what methods I've mentioned? You can always try a sclerotherapy, all right? We can use tetracycline, exactly. A sclerosint injection is a possibility where you can use the tetracycline as a sclerosint and try to establish this. This is very painful and hence not induced anymore. Now let's speak about the surgeries. All right. Yes, sir. Let me just start. Why would I want to choose Lord's plication? Why would I want to choose Jabolis procedure? Why would I want to choose excision of the sac? You mentioned three surgeries, correct? So where would I want to choose which surgery?
basically there are two methods by due to which a hydrocele is there. Either there is increased fluid production or there is decreased absorption. So in
Okay.
loss plication surgery, there's partial removal of the sac and we reduce the amount of fluid production in loss
Mm-hmm.
plication, while in the
Mm-hmm.
eversion of the sac, we divert the sac to the darkness muscles so that the fluid produced is absorbed by the subdermal lymphatics. And in excision of sac, we remove the entire sac which is producing the fluid.
Okay. But why the three surgeries, Samiksha? I mean, see, let's consider what your principle is correct. All right. Why not just excise the sac and be done with it? Why do you want to go ahead and have another surgery? Why have double A's procedure or why have loss plication? Why have Andrew's procedure as well? It doesn't make sense, right? If excision of a sac is good enough, why bother having these? Anyone else? Anyone else in this group? If the principle of surgery is to increase absorption and reduce production, why not just excise the sac and be done with it? Anybody? All right, let me just go ahead. Okay? Excision of a sac. This is usually done in a very long-standing case of a hydrocele. Now, in this condition, the hydrocele wall will probably be very thickened and very hardened. So, what you're going to do is, after giving a skin incision, opening the dartos muscle, getting down, open the sternocleidomastoid fascia, the atrial fascia, bringing the testis out, you identify that the sac is very thick. All right, and it is incapable of any further production. So what you're going to do is you're going to excise as much of the sac and leave it. So probably excision of the sac is done in cases where we have a long-standing hydrocele, or in case of a hematocele, or in case of an infected sac. All right, let's consider you do open, is that a pyocele? You do not identify the pyocele before surgery, you open it up. What are you going to do there? You're not going to do something called a loss plication or Jabolis procedure, right? You're just going to suture it and excise it and leave it out. Now, where is that used, a Jabolis procedure? A Jabolis procedure is used for a medium-sized hydrocele, okay? Or a hydrocele which is not extraordinarily large in size. Large plication is usually indicated for severely huge hydroceles. In this condition, I would probably go ahead and do a Jabolis procedure. What is a Jabolis procedure, Samiksha?
In Japanese procedure, we invert the sac with the darkest muscles.
You invert the sac?
With the darkest muscles.
Okay. And what happens
So that
after that?
the subdermal lymphatics can absorb the excess fluid that is produced.
Excellent. So what happened to the sac? You did avert the sac, correct? There was a sac. You are the primary operating surgeon. You gave an incision. You drain all the fluid. It was aspirated. You extended the incision above and below. The tunica vaginalis is now open. You averted the sac. What do you do after this?
Avert the sac, and we try to reduce the surface area of the sac by using
Yes.
Boston suture.
And give me a minute. There's this participant. Call message. Yes. Sivapriya, right? You're right. You have to suture the sac behind. The principle behind this is like removing your lab coat. Okay. All of you wear aprons and go to colleges. You come back, you remove a lab coat, correct? Now let's consider the lab coat has been fixed to your wrists. You remove the lab coat, and what was the buttons in front? You start buttoning them behind. All right. So whatever is being excreted is being absorbed. So what is Lord's plication here? If this is Jabolis procedure, what is Lord's plication? All right, I'll not waste more time. We'll throw in time. Lord's plication is you excise a part of the sac, and whatever sac is there, you start plicating it. You start suturing it above, and this suturing it above basically gives you a closure to this sac. Okay. All right. What are the complications of surgery, Samiksha? Well, let's be done with this as fast as possible. Do you have any complications with surgery?
Yes, scars to the skin, hematocele, pyocele,
Okay,
or any
okay,
damage to the epididymis.
okay. All right. Anything else? You could have hemorrhage. You can have infection.
Yes, sir.
Now, I'm specifically speaking about
Hematocele site.
complications of surgery. Correct?
Yes, sir.
You could have infection of the skin. You could have surgical site infections. The CDC classifies surgical site infections into four categories: one, two, three, and four. All of that is a separate topic for a separate day. All right. For right now, yes, hemorrhage, infections, injury to surrounding structures, which is the testis itself, or the epididymis. All right. Okay. It was a decent presentation, a decent uh, answering as well. This much should suffice most of your treatment. Whatever I have asked beyond this is excess. You will be assessed beyond this. Based on what you have answered, is sufficient for you to pass the exams. Now, let me mention that hydrocele is usually a short case. I repeat, hydrocele is usually a short case, assessed for 40 or 50 marks based on your own university, whichever place you're studying in. And this case, you will not be required to write down your history. You will be asked to take your history. You'll be given a small sheet of paper to just note down your clinical findings and present these findings. Okay, it will be for a short duration of time. So if you have come up here, it's sufficient enough for you to tell that this is fine. Also, I just wanted to mention what is testicular sensation?
It is the sickening feeling that they get on squeezing the testes.
It's lost in which all conditions?
In case of damage to the nerves about the testes, and in case of an hydrocele because we cannot get to it.
No, in case of hydrocele, you will still be able to precipitate the testicular sensation. Yes, the
Testicular
answer is
tumors.
testicular tumors in a chronic hematocele with significant calcifications, or in case of syphilitic orchitis. Remember, syphilis and leprosy injure the nerves. Syphilitic and leprotic orchitis we develop also testicular sensations. All right, let's proceed with the MCQs then.
Yes, yes.
All right.
I'll be starting with the first question. Hydrocele is labeled as vaginal when it is A. Limited to scrotum, B. Up to the inguinal canal, C. Communicating into the coelomic cavity, D. Up to deep inguinal ring.
I guess the participants can answer now in the chat box, right?
Yes, participants, you can
Yes,
answer in
sir.
the chat box if you know the answer so that we can move on quickly to the next MCQ. Okay, Preeti says C. Can you show the answer, Harshita?
It is A.
So, would you like to
To the
add something?
scrotum.
You know what? Actually, be done with your exam questions. I'll join back in a while, right? I'll just make sure I have. Harshita, do you have Daily in Love with you right now on your phone? Okay, we'll be done with the MCQs and then we'll speak. Yeah, let them continue with the MCQs.
Okay, sir. Next MCQ then.
Which is false about hydrocele? A. Almost always fluid is transparent. B. Get above the swelling. C. Testis is separate from swelling. D. Obscures the swelling. The question is which is false about primary hydrocele? Vaginal hydrocele.
Guys, you can be wrong. It was not your NEET or anything else, and no one is going to judge you, believe me. Just answer whatever comes to your mind. It'll be a little interactive, right? So,
Okay, so most of
The
the
correct
people have
answer
answered C. Yeah, can we move on to the answer?
C. Testis is separate from swelling. That's false about primary vaginal hydrocele. Next question. Which of the following is not true about hydrocele? A. Abnormal collection of serous fluid in tunica vaginalis. B. Not possible to get above the swelling in scrotal examination. C. Vaginal hydrocele is associated with 5% inguinal hernia. D. In congenital hydrocele, processus vaginalis is patent and connects with the peritoneal cavity.
Okay, so we have B as the leading answer. Let's see the answer then.
The option is
Okay,
B.
yeah.
Next question. Congenital hydrocele is best treated by A. Eversion of the sac, B. Excision of the sac, C. Lot's procedure, D. Herniatomy.
Okay,
The correct answer is D. Herniatomy. Next question, please. Cause of a large hydrocele in an infant: A. Patent processus vaginalis, B. Patent gubernaculum, C. Impaired drainage, D. Epididymal cyst. Okay, the correct answer is A. Patent processus vaginalis. Next question. Treatment of a large hydrocele in an infant is A. Is by repeated aspiration, B. Ligation of sac at the opening, C. Herniatomy, D. Eversion of the sac.
okay, so people are answering both C and D. So what is the correct answer?
The correct answer is C. Samiksha will continue.
Yes. Surgical treatment of antenatal hydrocele is recommended if it fails to resolve by A. 1 year, B. 2 years, C. 3 years, D. 4 years.
All right, I think we have our answer this time.
Yeah. The answer is A by 1 year. Next question, please. Lord and Jabella's procedure, this stands for A. Rectus prolapse, B. Fistula in anus, C. Inguinal hernia, and D. Hydrocele. We have the answer for this question. B. Hydrocele. The characteristic finding of a hydrocele is A. Cough and pulse, B. Transamination test, C. Get above the swelling and feel the testis, D. Reducing resistance. The answer, please. The correct answer is C. Get above the swelling and feel the testis. In Lord's technique, the sac is averted, the sac is excised, plication of sac, or partial sac removal.
Most people say A, answer B. And answer is B, extra removal. Next question, please. So we are done with the MCQs here.
All right. Can we just go back to the first MCQ once again? Okay. Let's just unmute all of you guys. I just want all of you guys to participate. Very simply, this is how you answer an MCQ, all right? An MCQ is just not answered by what the question says. Okay. Most often than not, a question will have four options. And of these four options, one is the correct one. But most often than not, you will not be given such easy questions in your NEET. And let's be very frank, you're either preparing for your next examination or a NEET examination or NLE or PLAB or whatever. All right, you will have to be preparing somewhere or the other. Now, so what you're going to choose, the best way of answering an MCQ is to rule out an options. Correct? Hydroxyl is labeled as vaginal when. All right. It's limited up to the scrotum, up to the inguinal canal, communicating with coelomic cavity, up to the deep inguinal rim. All right. Unfortunately, I don't have Bailey in my phone. My phone got rebooted. So what I'm going to do is I'm going to switch on the camera and I'm going to show you a photo on my tablet. Yeah.
Harshita, you can stop presenting, and can everyone please pin Sir on their phone or tablet or laptop so that you're able to better view it?
No, actually, I'm not able to show it. Give me a minute. I'm a little slow with our probable technology. Now, or what I can do is this. Give me a minute. Okay, so most of you guys study through which books, basically? Guys, most of you guys study through which book?
So, Lavin Devi and SRB.
Okay. Excellent. I'm sorry, I'm going to take a little more time and hopefully it should be okay. Yes, so what I'm going to do now is I'm going to share my screen in which I have these images. Alrighty. Okay. Are you guys able to see my screen?
Yes,
Right.
sir.
This is a direct image from Bailey and now, all right? So, remember we answered the MCQ, the first question. You answered whatever it was and what was the answer is. Very clearly, if you remember this image, I don't think there will be a problem ever for you to understand what the problem is. And this is a direct picture from Bailey, all right? So this, the first image, when it's stopping just at the level of the head of the scrotum or head of the testis, is probably a vaginal hydrocele. The B, the second part of it, this will be the infantile hydrocele, right? Now, when it is communicating to the peritoneal cavity, it will be a congenital hydrocele, and if it is only between those two, see, you can see the D image, and this will be the hydrocele of the cord, all right? This is how you understand to answer the questions. Now, if you go back to the question again, among those four options, one of these images is fixed to those four options, correct? Yes, no, some response, guys. All right, all right. The second image I wanted to show you guys was, sorry, this is Jabolis procedure. Sorry for the clarity of the image, but what you're going to do is you're going to excise the sac, you're going to pull it back behind the testis, and suture it up from top to bottom, not very tightly, but like a sleeve. All right. This is how Jabolis procedure is done. This is a classical image taken from Bailey. And this is Lord's plication. Basically, what you're going to do is in Lord's plication, you're going to open, excise the sac, and you're going to suture the inner layer of the tunica vaginalis to the outer layer of the tunica vaginalis, such that the tunica vaginalis gets crumbled. The sacs get crumbled in between. All right, and you will have a very rough kind of a edge around this testis. All right, this is what I wanted to show you guys. Let's continue with the presentation of the MCQ space. Also, Uh, a congenital hydrocele is treated by herniatomy. Why exactly? Anybody can answer.
So it's gonna result in hernia anyway. So
Sorry, come again.
it's gonna result in a hernia anyway, sir, because it's a congenital one.
So,
So we do a herniatomy.
exactly the question. Why exactly do you do herniatomy? What is the principle behind having a congenital hydrocele? That's a question, right? Right?
Yes,
A
sir.
congenital hydrocele is caused because of.
Patent processes vaginalis.
So, if a patent process vaginalis is there, you'd rather go ahead and do a herniatomy than having the
Yes, sir.
and the vaginal the tunica vaginalis is derived from which part of the abdomen?
So retroperitoneum.
No, it's derived from the peritoneum. All right. So
Okay.
it's a direct extension of the peritoneum, which actually gets obliterated, and hence you rather fix it and do a herniatomy and come out of it. All
Yes,
right.
sir.
This was what I wanted to tell you guys. Thank you. It was a nice session.
Thank you, sir.
Sir, is there anything you would like to add to the MCQs?
No, I think that should be comfortable as such. And please do make sure that you answer all the questions of the MCQs. And once you have the answers to all the four of them, then you will be able to answer it better. So no matter what MCQ is being given with that regards, you will be able to comfortably answer it. Well,
Does
if we are done with
anyone?
it, this then,
Yeah. What
does
does
anyone have
anyone?
any questions?
Guys, feel free to ask any doubts if you have. Like, if you don't want to speak out, you can always write it in the chat box.
Well, no questions at all. Excellent, man. I mean, Thanusha and Samiksha must have done a great job, no? All right. Let me ask a few then. A congenital hydrocele should be operated, can be waited for a duration of how many years? You told there's an MCQ, right, which tells that a congenital hydrocele will be operated at which point in time? No? Up to? And everyone answered it very correctly, I guess. Correct. 1 year. Who told 1 year, Sankar? I mean, which book tells it's 1 year, and how do you know it's 1 year, and why is it 1 year? I'm sorry, I didn't get the question. How do you differentiate from a hydrocele? Okay, you were told in clinical cases. Okay, now if you want to have a reference of which book you have to probably tell, you can always go back and tell that you want to. It is by there's a book called Campbell's Urology. Okay, Campbell's and Walsh Urology. You don't have to know this book per se, but after a bit of research, I did find that this book gives that at 1 year of age, if it doesn't subside, you can always operate. However, Bailey does not tell when. It just mentions that if it doesn't subside spontaneously or doesn't resolve spontaneously, you can go ahead with surgery. Okay, any other doubts you have? Questions, queries? Can testicular seroma be a differential diagnosis? What exactly do you mean by testicular seroma? Okay. Now, how would you define testicular seroma? A seroma is a collection of a serous fluid within the testis, correct? Now, what would be causing the testicular seroma? I'm not very, I'm not able to understand that question per se. What exactly is what is causing the seroma of the testis? A trauma or a malignancy? What exactly is causing a seroma of the testis? A seroma of the testis, a testicular seroma, very unlikely that it will develop outside the tunica vaginalis, right? Because outside the tunica vaginalis, you have a direct contact with the dartos muscle, and dartos has a really good blood supply to it. So, a very unlikely that you have a testicular seroma outside it. Anything which is developing inside it itself will be a hydrocele itself. That will be a hydrocele. So I don't think a direct testicular seroma per se should be a differential diagnosis. Anything else? Also, remember, guys, DAST, clinical methods of DAST dialysis, and most of your professors would have told it to you again and again. A rare diagnosis is rarely correct. So in your differential diagnosis, you will mention the most common ones which come to your mind the first. If you're going to have fever, even as a temperature, definitely it could be a lymphoma. Most certainly, no one is going to question it. But in India, you will mention tuberculosis before you mention lymphoma. Are we clear? Anything else? Doubts, questions, queries?
Okay, so
Okay,
if
then.
we have no more doubts, then we can end the session. Okay, then. So thank you so much, sir, for supervising the
Thank you.
session. It was a really great session. I'm pretty sure that everyone learned a lot from this session, and we're really glad to have
Still
you
just
here,
a
sir.
hydroxyl. Wish you guys all the very best. Learn well and have fun. Cheers.
Okay, thank you, sir. And I would also like to thank our case presenters, Samiksha and Thanusha, for presenting such a beautiful case and doing it so well. And I would also like to thank Harshita for helping me out in the case presentation. All right, guys, we'll be sharing the recorded session with you all, okay, on the Gmail IDs which you have provided. And thank you all for joining. Have a good evening.
Thank you.